Hello, future doctors and surgeons. Welcome back to this explainer. Today, we are diving into a completely high-yield clinical session specifically designed to decode patient safety, OT zones, and surgical positions. Okay, let's get right into this because आज का ये session is absolutely packed with direct, repeat concepts for your NEET PG and clinical exams. हम exactly उन्हीं points पे focus करेंगे जहां से direct MCQs आते हैं, straight from the source notes. तो एकदम ध्यान से सुनना and let's master this together.
So, here's our game plan for today. We're going to cover pre-op basics and IV lines, the surgical safety checklist, operating theater zones, patient positioning, air embolism, and finally, patient safety events. Let's get started.
All right, kicking things off with Phase 1, pre-op basics and IV lines. So imagine this. मान लीजिए आपका patient ward में admit हो गया है, and we need to prep them for surgery. Now notice the sheer detail required for a valid patient consent. It's really not just a quick signature on a piece of paper. You absolutely need proper identification, the diagnosis, exactly what procedure is planned, who the surgeon is, and a full procedure description. But the crucial point is right here. Procedure-specific complications. Rule yaad rakhna. Any complication that has a greater than 1% incidence must be explained to the patient. Ye strictly tested rule hai exams mein. You also have to mention the benefits, any alternate procedures, and you have to ensure you get signatures from the patient, the surgeon, and a witness. The whole shebang.
Now, when we talk about choosing IV cannulas, this is a massive high-yield topic. Let's go from narrowest to widest. Yellow is 24 gauge, pushing about 13 ml per minute, and blue is 22 gauge at 31 ml per minute. These are mainly for your pediatric patients. Then we have pink, which is 20 gauge at 67 ml per minute, but examiners के favorites कौन से हैं? It's the green 18 gauge, which pushes out about 96 ml per minute, gray at 16 gauge pushing 236 ml per minute, and especially that massive orange 14 gauge pushing a whopping 270 ml per minute. याद रखना, whenever you have a patient in shock needing massive fluid resuscitation, orange is your ultimate go-to.
पर क्या होगा अगर IV line ठीक से काम ना करे? Like, what is the absolute most common complication of IV lines? Well, it's superficial thrombophlebitis. And the clinical presentation is a classic buzzword. You will see a tender cord-like swelling at the site. अगर ये phrase question में दिखे, immediately mark it. And the management? Super simple. Just apply a topical heparanoid.
Moving right along to Phase 2, the surgical safety checklist and blood loss.
Okay, consent हो गया, IV लग गई. Now the patient is actually being transferred to the OT. Enter the WHO's surgical safety checklist. This checklist has 3 strictly chronological phases. Sign-in happens before the induction of anesthesia, जब patient ward से OT complex में shift होता है. यहाँ हम identity, site, procedure and consent verify करते हैं. Then comes timeout. This is exactly before the skin incision. And finally, sign out, which happens right before the patient leaves the operating room, जहां instruments or sponge count check करते हैं. And guys, let me point out a huge trap here. Note down that there is no time in phase. Examiners absolutely love to put time in as an option just to confuse you. Mat fasna.
So, intraoperatively, how does a surgeon quickly estimate actual blood loss? You take the blood in the suction minus the irrigation fluid, or you visually weigh the mops. A standard soaked mop equals roughly 100 cc's of blood loss. But if you see a fistful of clots on the field, that instantly indicates around 500 cc's of blood loss. Yet quick visual math surgical decision-making के लिए बहुत ही critical है.
Next up, Phase 3, navigating the OT zones. Now we're basically walking into the physical architecture of the operation theater. The OT complex is divided into 4 main zones based on decreasing levels of contamination. First is the protective zone, and this includes your change rooms, transfer bay, and pre- or post-op ICU rooms. Next, you step into the clean zone, connecting the protective area to the sterile areas. Here you'll find the equipment storeroom and maintenance workshop. Then comes the holy grail, the aseptic zone, which is the actual OT itself. And finally, the disposal zone for biomedical waste. Remember, the flow of traffic हमेशा unidirectional होना चाहिए.
All right, Phase 4, patient positioning and high-yield complications.
Okay, patient OT में आ गया है. गलत positioning की वजह से severe clinical headaches और morbidities हो सकती हैं. Let's look at these surgical positions. First up, the supine position. Head and feet are level. This is the most common position, generally used for abdominal and breast surgeries. Next is Trendelenburg, where the head end is low.
This is heavily used in pelvic surgeries to keep the bowels out of the way. Then we have reverse Trendelenburg, where the foot end is down. This is classic for upper abdominal surgeries like a laparoscopic cholecystectomy. So the crucial point here is the complication. In a lap chole, CO2 collects below the right dome of the diaphragm, which irritates the phrenic nerve. And that causes classic right shoulder tip pain. ये most common complication है. Mark it.
Moving on, we have the lithotomy position, very common in OBGYN procedures, urology stuff like TURP and hemorrhoid surgeries. Exam में क्या पूछते हैं? They always ask about the nerve injury. If the legs are not supported properly, the common peroneal nerve gets compressed against the stirrups. Foot drop हो सकता है, right? Then there's the lateral or kidney position. We use this for thoracotomy or nephrectomy. Here, due to the hyperextended arm, there is an increased risk for brachial plexus injury. Always protect those nerves.
Just a few more key positions to round this out. The prone position is standard for spinal or pylondial sinus surgeries. Then there's the sitting or Fowler's position. This gives great exposure with a bloodless field for posterior cranial fossa surgeries, but it has a terrifying disadvantage, which we'll get to in just a second. Notice the jackknife position here? It's literally considered completely obsolete now. Pele hemorrhoid surgeries के लिए use होता था, but it carries a massive risk of positional asphyxia. Finally, the Lloyd-Davies position, which is basically Trendelenburg plus lithotomy. It's famously used in rectal cancer surgeries. But hey, let's go back to Fowler's position for a minute, because that brings us perfectly to our next major clinical emergency.
And that is Phase 5, air embolism management.
Let's change the pace up a bit here because things just got real serious. Air embolism is an absolute intraoperative nightmare. So Chozarat, you're doing a thyroid or neck surgery with the patient sitting upright in Fowler's position. Gravity is constantly pulling the venous blood down. Suddenly, 50 to 100 cc's of air is sucked right into an open vein. Kya hoga patient ko table bar? Well, the moment that air enters circulation, it travels straight to the right side of the heart and creates an airlock. This completely dysregulates cardiac functioning. The clinical picture? The anesthesist is going to scream that there is sudden desaturation, severe dyspnea, and profound hypotension. So, vitally, how do we prevent this in Fowler's position? You always ligate the vein before cutting and constantly irrigate the surgical field so that if a vein does open, it sucks in water, not air.
But if it actually happens, what is the emergency management? You immediately put the patient in the Durant position. ये नाम अच्छे से याद कर लो. Durant position. It means placing the patient left lateral, so the right side is facing up, and raising their legs up. This traps the air bubble in the apex of the right ventricle, preventing it from blocking the pulmonary outflow tract. You follow this up by actively aspirating the air using a direct puncture or a central line. Direct example hai ye, don't forget it.
Finally, let's wrap things up with Phase 6, Patient Safety Events Terminology. Okay, take a deep breath. The patient is stabilized. The surgery is over, and we're in the post-op review. Now we need to accurately report what happened using standard patient safety terminology. Let's compare 3 vital definitions. First, an adverse event. This one is straightforward. It's an incident that results in actual harm to the patient. But the confusion almost always lies between a near miss and a no-harm event. दोनों के बीच का subtle difference समझना बहुत ज़रूरी है. A near miss is an incident that could have resulted in harm but did not reach the patient, either by pure chance or timely intervention. Basically, you caught the mistake before it touched the patient. A no-harm event, on the other hand, is when the incident actually does reach the patient, it happens, but by sheer luck or mitigating circumstances, it results in 0 injury.
So let me leave you with a quick scenario to test your understanding. मान लीजिए, a patient actually receives the wrong IV medication. The drug goes into their vein, so the event absolutely reached the patient. But fortunately, they have no allergic reaction, no injury whatsoever. Which specific safety event did you just witness? Is it a near miss or a no-harm event? Think about the definitions we literally just discussed. If the drug reached them but caused no injury, it's a no-harm event. But think about this before our next session. What if that same exact wrong drug was pushed? It caused a brief cardiac pause, but the patient was immediately resuscitated to full health with absolutely no permanent damage. Is that an adverse event or a near miss? Keep revising these high-yield topics from today's session, future doctors, because the lines in real clinical practice blur really fast. Keep studying hard, and I'll see you guys in the next one.